Yeah, come.
Good morning, everyone. I welcome you all for the next session, Ocular Immunology. So the panelists are Dr. Sarita ma'am and Anurag and Dr. Asta Singh, Jaya Gupta ma'am and Tushar. So our speakers are, the first speaker is Archana Kumari. Okay. So she'll be speaking on blast syndrome. I welcome you to the dais.
Thank you, ma'am. Good morning. Today I'll be presenting a case of Blau syndrome. So a 10-month-old female baby was born with features of bilateral uveitis, hypopigmented skin lesions, and lethargy. Subsequent workup revealed the possibility of Blau syndrome or infantile sarcoidosis. The patient was managed with a combination of systemic, topical, as well as surgical management. So in 2012, the child first presented to us at 10 months of age with abdominal distension, recurrent loose stools, progressive skin lesions, swelling of hands and feet since 4 months of age, and failure to gain weight. General examination revealed pallor, edema of both hands and feet, depigmented hair, hypopigmented scaly lesions over the abdomen, forearm, and lower limbs, and oral candidiasis. Ophthalmological examination revealed bilateral anterior uveitis with a festooned pupil, multiple posterior synechiae, and scattered lens opacities in both eyes. We started her on prednisolone eye drops Q3 hourly in both eyes, along with timolol and atropine. Systemically, from pediatric rheumatology, they had started on methotrexate fortnightly 5 mg. In 2017, the cataract in the left eye progressed. The vision in the right eye was 612, vision in the left eye was 636. Along with the progression of cataract, she had an exacerbation of her uveitic activity, so we had managed with adalimumab. After the uveitis was controlled, the cataract surgery was done in the left eye with the PCIOL implantation of plus 20 diopters. Intraoperatively, we found mild pallor, multiple sheathed vessels, and multiple scarred CRA scars. Post-op, after the left eye cataract surgery, was only 618. Post-operatively, OCT macula was done and showed a shallow sensory neural detachment in the left eye. In 2020, till 2020, the shallow SND was persistent. The parents were counseled for intravitreal injection of Ozurdex, but they were not willing in the beginning. So we tried to step up the immunosuppression. Pulse IV methylprednisolone was tried, but the detachment remained the same and vision remained the same. Finally, they agreed and underwent Ozurdex, but still, despite the Ozurdex, the persistent SND was persistent. In 2021, she developed high IOP and open angles, no inflammation, and which was in the left eye, which was uncontrolled despite maximum AGMs. So she underwent a TRAB in the left eye. Post-op IOP was controlled, but vision was just the same with the SND persistent. In 2022, the right eye had a BSK with a festooned pupil and cataract with vision of 618. In the left eye, it was status post-TRAB and status post-cataract surgery with the shallow SND still persistent. Vision now dropped to 3/60. So in 2023, this is a color fundus photograph. The right eye showed peripapillary atrophy, attenuated vessels with sheathing, macular scar, and multiple CRA patches. The left eye had a hazy view. There was a pale disc with mild blurring of margins, attenuated vessels, and shallow retinal detachment. The investigations that were done in 2013 was CBC showed a microcytic hypochromic anemia. Skin biopsy showed granulomas with Langerhans giant cells. Liver biopsy showed granulomatous inflammation with Schwann bodies. Stool was positive for occult blood. Endoscopy showed granulomatous duodenitis. And colon biopsy showed granulomatous colitis. However, NOD2 gene mutation was negative. So we were debating whether it could be Blau versus infantile sarcoidosis. In 2023, that was during the last visit, this is the OCT showing the shallow sensory neural detachment still persistent. So I'm just going through the interventions again. Initially, when she had come, we had given methotrexate and mycophenolate mofetil and topical steroids. Then in 2012, that was in 2012. Then 2017, we added adalimumab, and she underwent left eye cataract surgery. Then 2020, Ozurdex was tried for the SND. 2021, TRAB was done. 2020, she underwent right eye cataract surgery and left eye pars plana vitrectomy with silicone oil. And she also underwent diode CPC from outside. So the outcome in 2023 in the right eye was PCIOL with BSK and festooned pupil. The left eye was status post cataract surgery, status post trab with a flat vascularized bleb, and status post plasplanar vitrectomy with silicone in situ. So this was the last follow-up in December 2023. The left eye vision was now hand movements, PL plus PR inaccurate. The guarded visual prognosis was explained to the parents, and we had planned for silicone oil removal at a later date. She is now on brinzotam, homide, and pred. So Blau syndrome is a rare autoinflammatory granulomatous disorder. It is usually dominantly inherited, but can also be sporadic. Chronic inflammatory syndrome, it has a classic triad, that is granulomatous dermatitis, symmetric arthritis, and recurrent uveitis. And it has striking similarities with early onset sarcoidosis. Most patients with EOS also have mutations in the CARD15 or NOD2 gene. Therefore, some authors are saying that Blau syndrome and EOS are the familial and sporadic forms of the same disease. And it is the only autoinflammatory disease with a gain of function mutation to show granulomatous inflammation. The first step of therapy, of course, is corticosteroids, and successfully, if there is no satisfactory response, additional treatment with immunosuppressants can be tried. But the results with biologics like anti-TNF, in this case we use adalimumab, are different, particularly with regards to ocular morbidity. So why I chose this case is because even though it's a rare entity, it is gaining significance as an important cause of pediatric uveitis, especially in very young children. And it is quite underreported in India. The recent creation, they are trying to make an international registry so that we can provide novel insights into the symptomatology and etiology of this genetic disorder. Also, proper family history and genetic counseling is essential, and inter-department collaborative efforts between the rheumatology, pediatric rheumatology, and ophthalm is needed for good outcomes. And yes, thank you.
I think it's a very good presentation, Dr. Archana. And since these rare diseases are now becoming very important in India, so I'll just quickly ask two questions. Was adalimumab continued lifelong, or was it stopped? You said in 2017 it was started.
Yes, ma'am.
It was continued.
It was continued.
Despite that, she had progression.
Yes, ma'am.
And what about the other, like dermatitis and arthritis for her?
Dermatitis was under control, ma'am.
Arthritis was also under control.
It was the uveitis that was...
All right. Any more questions? So we can quickly go to the next. Yes. Dr. Ananya. She will be presenting on anterior uveitis in a young patient. I think uveitis in young patients are now getting very important because of these new biologicals, and we need to keep their eyesight maintained forever.
Is Dr. Ananya here?
So Ananya is not there?
Bharat Manda is here.
Before that, Kalapriya.
Dr. Kalapriya.
So we can just confirm who all
Okay.
are. Just take the names.
Yeah. So, is Dr. Kalapriya you are?
Your name is?
You come up.
Bharat. Okay.
You come up.
So, Dr. Ananya, Dr. Kalapriya, you're not here. Then we can have
Kalapriya.
Sakshi.
Sakshi Dhaniwal is here. Sunny is here. Yeah, you be ready with your presentation.
And the other one?
Good morning. My topic for today's presentation is posterior scleritis in a child.
Sunny said was
My patient is a 10-year-old resident of Bangkok. Since February 2023, she developed ocular complaints of swelling, redness in right eye associated with pain for 2 days. Her systemic complaints were low-grade fever, nausea, vomiting with intermittent abdominal pain. Relevant history of viral fever lasting for a week in the month of April. No complaints of diplopia, no history of upper respiratory tract infection, treated as conjunctivitis with topical antibiotics. Pediatric consultation was done and she was treated symptomatically. From 6th to 12th June, there was incomplete resolution of symptoms and she was started on topical steroids. On 12th June, there was no resolution of symptoms, reappearance of lid swelling, right-sided headache and low-grade fever which subsides on its own. From 14th to 15th June, there was periorbital edema which increased, persistence of redness, systemic condition of lethargic, nausea, vomiting continued with low-grade intermittent fever. Then on 15th June, She had painful ocular movements in all gazes in the right eye. Her visual acuity unaided was 6 by 6 in both the eyes with IOP normal in both the eyes. Anterior segment examination of right eye showed periorbital edema, chemosis, congestion with no RAPD. Posterior segment examination of right eye showed media clarity grade 1 with optic disc edema and rest within normal limits. Left eye examination was within normal limits. This was CE MRI brain and orbit report of Bangkok, which suggested proptosis in the right eye with involvement of lateral rectus, superior rectus, inferior rectus, lacrimal gland, which showed mild thickening and enhancement. With the history and with the course, they have diagnosed as it as orbital cellulitis over orbital inflammatory syndrome, right eye, and suggested for parenteral antibiotics. She moved to Lucknow, that is Center B, and she was started on IV antibiotics, Targocid, ceftriaxone. Along with that, she was started on 1 mg per kg body weight oral prednisolone. She responded well. Her preseptal edema settled down, nausea, vomiting disappeared, chemosis improved. This was the MRI brain and orbit axial scan, which showed increased posterior scleral thickening, but the periorbital inflammation reduced, proptosis also reduced compared to the previous MRI. This was ultrasound AB scan, which showed disc edema and subtenon fluid collection, suggestive of posterior scleritis. The diagnosis was orbital inflammatory syndrome. When she presented to our center, she was already on tapering dose of steroids, and the symptoms were resolved. Her examination, ocular examination, revealed 6 by 6 vision in both the eyes unaided. Ocular movements were full and free in all directions and gazes in both the eyes. Color vision was normal. Contrast sensitivity was normal. Anterior segment examination was normal in the right eye with no RAPD. Posterior segment examination, fundus showed grade 1 media clarity with the disc edema, and rest of the examination was normal in the other eye. This was the fundus showing grade 1 media clarity and the optic disc edema of the right eye, and this was the left eye image, which is normal. My differential diagnosis, this is the long list of my differential diagnosis. We have thoroughly investigated her, and her CRP was increased, ESR was increased, and other rheumatoid factor ACE and ANCA and ANA profile was all negative. AB scan showed, which was done on 5th July, showed disc edema, T sign which suggestive of posterior scleritis. Axial scan showed increased retinochoroidal thickness with T sign. My final diagnosis was idiopathic orbital inflammation with posterior scleritis. Given the need for prolonged immunosuppression, she was initiated on oral methotrexate, continued for 2 months, then started on biologics, adalimumab. Now patient has symptomatically she is free, and presently she is on adalimumab. These are my references. Thank you.
So methotrexate, what is the dose that was started?
Ma'am, she was started on subcutaneous, ma'am. Maximum dose was given was 20 mg, ma'am. It was given for 3 months from August, September and October. Then she was shifted to adalimumab. Subcutaneous adalimumab, she was given 20 mg.
Okay. Any specific treatment you could make, because all those tests which you did, was it an autoimmune disease? Like you started antibiotics, you started steroids, then adalimumab?
That disc edema could be pediatric sarcoidosis also. We have ruled out sarcoidosis. There may be IgG4, we have ruled out IgG4, ma'am.
So from the test, nothing could come out positive.
Yes,
so it was exclusion. It was a diagnosis of exclusion that it is autoimmune, and you started on adalimumab.
Yes, ma'am. Yes, ma'am. There are literature suggests that there will be a posterior scleritis, and later on they may develop Conn's disease or any other autoimmune disease.
Because with now adalimumab is just like panacea for so many diseases. So just can you tell what all you have to be careful for a young patient and others also? If the patient is on adalimumab, you have to be careful about some of the systemic problems. Can you tell?
Ma'am, there may be demyelinating disorders which may unmask at an early age. Demyelinating disorders which may unmask with adalimumab. Otherwise, local reaction.
Even tuberculosis have to be checked again and again because it is suppressant, immunosuppressant.
No. There was a point, ma'am, we did not do ocular tissue biopsy as we did not get consent from the parent. And when patient has presented to us, she was asymptomatic, except the disc edema. Others were, there were no signs of periorbital chemosis.
If you were to do a biopsy, from where will you take the biopsy?
Tissue biopsy, ma'am, if she has painful ocular movements, we would try to take from the muscle.
The immunosuppressive therapy, are you, is the rheumatologist or the medicine department is
We
doing,
have
or you're
taken
doing it yourself?
consultation of rheumatologist, ma'am, in consultation with the rheumatologist. Thank you.
Okay, is Ananya here? Dr. Ananya, Dr. Kalapriya?
Divya Kanduri.
Oh, okay, only learned once.
Sakshi Damiwal.
She has also loaded her presentation. So we can straight away ask.
Your Sakshi
From-
Damiwal. Please, if any presenters are there, please come to the front.
So come,
Please come to the front.
introduce yourself and please come up. Who is she?
Dr. Sakshi, please come. So as Madam said, any of the presenters are here, please come forwards, and so that we don't keep calling and wasting time in that, rather we can discuss. Dr. Sunny, please raise your hand. Dr. Sunny, please come in the front. Dr. Mayuri, please come. Dr. Divya Kanduri, she's not there. Dr. Soumyadeep Mondal, please come. Dr. Priyanka, Dr. Sayali Shah, not there. Dr. Sayali is not there. Dr. Shrini is also not there. So we have very few speakers, so we can have a good discussion. We have time for discussion, so we can all discuss properly. All right. So Dr. Sakshi, please.
Good morning, everyone. I'm Sakshi Dhamiwal from AIIMS Bhopal, and today I will be providing a brief overview of few cases of peripheral ulcerative keratitis with autoimmune pathology. So PUK is known to have frequent association with systemic disorders and thus serves as a diagnostic indicator for underlying inflammatory basis and thus necessitates specific treatment strategies. So we report 6 cases of PUK detailing their management strategies, visual outcomes, and the need for timely intervention. So my first case is a Hep B positive patient which presented with 5 clock hour epithelial defect and 80% stromal thinning. So he was managed with bandage contact lens with tissue adhesive application. Following 2 weeks of which further stromal loss is halted, leaving mild stromal haze due to post-op inflammation. Next, I have 2 cases of rheumatoid arthritis. First had a similar clinical presentation as my previous case, but he was recurrent post-BCL application. So in this case, limbal conjunctival resection with glue BCL application was done. Another case had an inferotemporal thinning which further complicated to paracentral corneal perforation. So this case was managed with multi-layered amniotic membrane grafting using inlay and onlay technique. Next, I have a patient of autoimmune hypothyroidism which presented with corneal perforation and surrounding stromal melt. This case was managed with banana patch grafting using donor corneoscleral tissue. His tectonic integrity was preserved post 6 months. However, he developed glaucoma due to chronic steroid uses. Next, I have a patient who came with the necrotic foci in sclera and corneal melt with uveal prolapse. So he had respiratory infections also, respiratory breathing difficulties also. So this case was managed with IV cyclophosphamide, weekly intermittent pulse therapy and IVMP. Following 2 weeks of which there was epithelialization of defect, fading of stromal infiltrates and resolution of signs on chest X-ray was seen. So this case highlights the importance of medical intervention in cases of PUK. Currently, this patient is planned for patch grafting. My next case had a 3-quadrant corneal melt. So this has to be managed with penetrating keratoplasty and he was kept on long-term immunosuppression therapy. So these are the comparative visual and structural outcome of all my patients. So my take-home message should be that the major goal should be in the management of PUK, firstly, to reduce the morbidity and mortality associated with the underlying autoimmune condition. Secondly, to preserve the ocular integrity. And thirdly, should be the visual rehabilitation. And lastly, I would say that always assess for any signs of opportunistic infection as these patients are on long-term immunosuppression therapy. And with this, thank you, everyone.
I think very well presented. Dr. Asta would like to ask a few questions and others, please.
In the patient that you performed conjunctival resection, so can you tell me what is the ideal or a preferred time to perform a conjunctival resection in patients with PUK?
Ma'am, it should be performed as soon as possible. Like if the patient is not responding to any treatment, there is no infective pathology behind, there are no signs of infection. And we have to start the patient on, there are signs of correlation with the collagen vascular diseases. So we should give it as soon as possible.
So ideally you would want the inflammation to subside a little, because if you perform too quickly, then it might not work. So you should control with the maximum immunosuppression, topical or systemic, and then go in for a conjunctival resection, and preferably you should take 2 clock hours more from both superior and inferior and up to 4 to 5 millimeter behind to remove all the source of your collagenase and inflammatory mediators. Jaya ma'am?
Well said. That was very well said, Asta. I think the essential point she has covered it. After the systemic control, like once the rheumatologist or immunologist has taken care of, then only we should intervene.
The patch graft that you have taken is quite bigger than the size of your perforation. So that big patch graft is not necessary actually. Just you close the perforation and keep the patient on immune suppression. That will be enough, because it's going to cause a lot of astigmatism, and to deal with the patch graft later is also difficult.
Thank you, ma'am.
No, so, for the sake of the residents, can we discuss what investigations we usually do when we have a case of PUK that comes to us?
The basic PUK workup, Hashika.
Dr. Sakshi.
We have to get all the blood investigation like CBC, ESR, CRP, and we have to rule out infective pathology also. So MON2 test for SLE, ANA, NCA, you have to rule out relapsing polychondritis. So we have to ask relevant information, like if there is any symptom, he has any other symptoms other than ocular symptoms. So that chest X-ray we have to take. And baseline WBC count we should check, because these patients we have to start on immunosuppression therapy. So there are chances of the immunosuppression and nephrotoxicity also. So
your first patient was hepatitis B positive, so we also have to look for these viral.
Yes,
Hepatitis B, C.
yes, ma'am. Thank you, ma'am.
So we can go on to our next speaker, Dr. Sunny. Spontaneous healing of bilateral Murren's ulcer.
Ma'am, shall I start? Good morning, everyone. I am Dr. Sunny from Assam Medical College, and my topic is spontaneous healing of bilateral Murren's ulcer. Murren ulcer is a rare autoimmune disease characterized by progressive circumferential peripheral stromal ulceration with later central spread. Corneal perforation is much more common in Murren ulcer. Murren ulcer is more or less associated with Hep C, trauma, and parasitic infections. Associated with systemic autoimmune disease and corneal infection should always be ruled out. My patient, she is a 60-year-old female. She presented to our department with diminution of vision from the past 2 years and redness from the past 6 months, intolerance to light in both eyes from the past 2 months. On ocular examination of right eye, Eyebrows, eyelids, eyeball were within normal limit. In conjunctiva, there was mild conjunctival congestions were seen. On cornea, conjunctiva as well as blood vessels encroaching over the cornea, leading on to the loss of transparency. There were multiple grades of opacity, such as glaucoma and macular grade opacities were seen, both in central as well as paracentral area. There was a limbal mass of 2 cross 2 millimeters seen on 12 o'clock position with loss of architecture of limbal palisades. Pupil were irregular, which was sluggish reactive to light. Lens and fundus were not able to evaluate. Ocular examination of left eye, eyebrows, eyelids, eyeballs were within normal limit. On conjunctiva, there was mild congestions on the nasal side. On examination of cornea, there was a crescent-shaped juxtalimbal destruction of corneal stroma, which was extending circumferentially from 4 o'clock to 11 o'clock position was seen. There was an undermined leading edge at 11 o'clock position. There was overhanging edges extending from 4 to 11 o'clock position. Blood vessels encroaching over the thinned out cornea in the nasal side, extending from the limbus to the overhanging edge of the ulcer. Lens, it was NS grade 2. On investigation, USG B scan, there was bilateral cataractous changes and vitreous degenerations in right eye. USG whole abdomen, bilateral mildly raised renal cortical echo texture was seen. On keratometry of left eye, K1 was 49.75 diopter at 135 degree and K2 40.5 diopter at 35 degree with BCVA of both eye hand movement close to the face. Rheumatoid factor, ANCA and ANA came out to be negative. My patient, as she refused for peritomy as well as amniotic membrane transplantation in her left eye, so she didn't give consent for the operation and was managed conservatively with plain steroid as well as adjuvants along with painkillers. After 2 weeks of follow-up, in my patient, congestion and vascularization over the cornea were decreased, with best corrected visual acuity on the left eye improved to 1/60. Clinical implication in young patient, it needs to receive an immediate interest as visual morbidity stays enormous in this range. Recent studies have identified calgranulin C, a protein both involved in the immune response to parasitic infections and which also happens to be found in corneal stroma as perhaps central to the pathogenesis of Murren's ulcer. More research and trials needs to be conducted to permanently derive a proper therapeutic regimen for curing this destructive disease. Since there might be an autoimmune mechanism involved, steroids and other immunosuppressive therapies have demonstrated an effective long-term response. Muthaiya Srinivasan et al. Concluded that Murren ulcer is a rare and potentially blinding eye condition observed not infrequently in the cornea clinic at Arvind Eye Hospital. Men are affected more than women and may present with either unilateral or bilateral disease. Tarun Sood et al. Concluded that bilateral Murren ulcer in young population needs to be given an immediate attention as visual morbidity remains significant in this variety. These are my references. Thank you.
So the patient,
Please.
so the patient responded to the topical steroids.
Yes, ma'am.
Then I think the title, spontaneous resolution. Yeah.
No surgery was required because she refused surgery.
Yes,
So with topical steroids, she became all right.
yes, ma'am.
Right. All right. So it can be a little bit modified, the topic, because it's not spontaneous means absolutely no treatment given. And no surgical treatment was given. But
Yes, ma'am.
yeah, that's what.
Because 90% of Murren's ulcer patients, they respond to the topical steroids. So they might not need, all the patient might not need surgical intervention.
But ma'am, in my case, there was a corneal perforation, uveal tissue prolapse was there. For that also she refused to, for example, banana graft. So we went to steroid, ma'am. There was a pseudo cornea formation, ma'am. That's why.
Systemic steroids were given?
No, ma'am. Systemic steroids were not given.
You could have given systemic steroids also.
Nothing systemically you gave.
Ma'am, rheumatoid factor, it came out to be positive, but it was mild positive. We took a medicine consultation. They said that rheumatoid factor is just 14.6, which can be considered as 14.6, ma'am. And normal value lies below 12. Medicine people, they told that 14.6 can be considered as negative. And you can...
All right, thank you. So we can go on to our next speaker, Dr. Mayuri Phatak. She'll be speaking on VKH syndrome.
Good morning to all.
Your GNC then has too many cornea surgeons on oculoplastic vertigo.
The audiovisual team.
Vogt-Koyanagi-Harada disease is defined as a bilateral granulomatous panuveitis with or without extraocular manifestations like headache, tinnitus, neck stiffness, hearing loss, and integumentary findings affecting young adults. There are three clinical entities, namely complete VKH, incomplete VKH, and probable VKH. All three categories of the disease have absolute requirements of bilateral eye disease, absence of history of trauma, no clinical or laboratory evidence suggestive of another uveitic cause. So a 36-year-old female presented with complaints of eye pain and blurring of vision since one day. Uncorrected visual acuity in both eyes was 6/12, not improving by pinhole, and a near vision of 6/18 on reduced Snellen. The refraction showed hyperopic error. Color vision was within normal limits, and on slit lamp examination, both eyes showed anterior segment which was within normal limits. The retina showed multiple pockets of subretinal fluid over the posterior pole and peripapillary SRF. This is a fundus photograph of both eyes showing multiple pockets of subretinal fluid. This is an autofluorescence of the same showing areas of hypoautofluorescence corresponding to the pockets of subretinal fluid. The OCT image showed bacillary layer detachment and multiple septae forming compartments or pockets of the subretinal fluid. The FFA showed multiple pinpoint areas of hyperfluorescence which corresponded to the pockets of subretinal fluid along with disc staining, and a diagnosis of probable VKH disease was made. Patient was treated with 1 gram of IVMP per day for 3 consecutive days, after which she was shifted to oral corticosteroids which were tapered weekly, and adjuvant treatment was given. On 1 month follow-up, the best corrected visual acuity improved to 6/9 parts with near vision of N8 in the right eye, and left eye was normal. On slit lamp examination, retina showed few hypopigmented spots at the macula with peripapillary SRF. The OCT at 1 month showed resolution with slight SRF in the right eye. Left eye was normal. On subsequent follow-ups, patient was maintained on azathioprine and was monitored for CBC, LFT, and RFT, and was asked to come for follow-up every 3 monthly. So VKH is an important cause of bilateral loss of vision and has a good visual prognosis if aggressive treatment is initiated during early stages. The most common finding in acute cases is serous retinal detachment followed by disc edema, and in chronic cases, depigmented fundus. A study showed that VKH occurs less frequently in India than in Japan and United States. Extraocular signs are far less common in Indian population, and visual prognosis is good in patients presenting within 1 month of onset of symptoms. In a retrospective analysis by Lodi et al. Of 32 patients of VKH in South India, reported it to be more common in females, and showed that posterior uveitis is the most common initial manifestation. Initial aggressive treatment with IVMP and immunosuppressives gives a good visual outcome without recurrences. So VKH is a bilateral condition commonly seen in females in the 3rd or 4th decade, which can cause vision impairment. It is usually managed with systemic corticosteroids, and the patient can be maintained on immunomodulatory therapy. The differential diagnosis we considered was bilateral CSCR, which was ruled out with help of OCT and FFA, and sympathetic ophthalmitis, for which we have to rule out history of trauma. Thank you.
I think it's a very important topic which you covered, VKH, because in this I'd like to ask you, did you rule out tuberculosis in every way?
Yes, ma'am.
So you didn't mention what all investigations you
We
did.
had done blood investigations like CBC, blood investigations like CBC, ESR, CRP, MAN2, chest X-ray, and TB Gold.
Just chest X-ray would not pick actually. You have to go in for HRCT and ultrasound abdomen because you're giving very high steroids. And we've also had cases like this, and they have turned out to be tuberculosis so common in India because the systemic features, as you said, are not present in India as much. So it is also a very long treatment which need to be done. So tuberculosis has to be really ruled out. Thank you.
Mandal. Dr. Soumyadeep Mandal.
So we have another Vogt-Koyanagi-Harda syndrome being presented. It is a very important topic, as we just mentioned, because it really mimics tuberculosis, has to be ruled out in all.
Shall I start, ma'am?
Yes.
So today I am going to present a rare case of Vogt-Koyanagi-Harda syndrome in a young female patient. My patient was a 21-year-old female who presented with sudden onset dimness of vision in both eyes for last 2 days, and her best corrected visual acuity was finger count 1 feet in both eyes, and dilated fundoscopy revealed disc edema along with extensive serous retinal detachment involving macula. Ocular symptoms were preceded by low-grade fever, headache, and tinnitus. Usually, VKH presents as bilateral panuveitis, but in our case, the anterior segment was spared and the disease manifested as posterior uveitis. So, upon OCT, there were certain findings which are very much sensitive for diagnosis of VKH, like there was subretinal membranous septa, folds of RP, there were fluctuations of internal limiting membrane, hyperreflective dots. These are very specific findings. Then the patient was started IV methylprednisolone, that is pulse dose, for 3 days, and after 3 days he was converted to prednisolone 60 milligram per day, and we also added one immune modulator, mycophenolate mofetil 1 gram BT. And the outcome was excellent. The patient presented with so much of exudative retinal detachment, but after 7 days you can see minimal amount of subretinal fluid is present in the right eye as well as in the left eye. So the patient was closely followed up every month for recurrence, and best corrected visual acuity was 6.6 maintained in both eyes, and every month we were tapering 10 milligram corticosteroid, and now after 5 months of maintenance, when the patient is recurrent free, the patient is on lowest maintenance dose of 10 milligram of oral corticosteroid and mycophenolate mofetil 1 gram BT. The patient is also counseled regarding family planning. So excellent visual recovery can be obtained by early initiation of systemic corticosteroids in VKH syndrome, and initiation of immune modulators like mycophenolate mofetil helps us in 3 ways. First, it helps us in reducing the corticosteroid dose. Second, is systemic adverse effects, and third, the recurrence of exudative retinal detachment. Thank you.
Thank you, Dr. Soumyadeep. Again, I would like to say, what investigations did you do to rule out tuberculosis? Even if they have these 3 signs which you said, very important OCT 3 signs which you mentioned. Can you just repeat them, the 3 signs?
Yes,
very important, very...
First is subretinal membranous septa, then fluctuations of internal limiting membrane and hyperreflective dots.
And
Hyperreflective.
bacillary layer detachment.
Yes.
These are very important points, but these are seen in tuberculosis also.
That's
so
why we have to rule out all type of infective causes which are causing serous retinal detachment, like any kind of tuberculosis. We did IGRA, we did chest X-ray, sputum A, Biman2 test, everything was done.
So before starting your high doses of IVMP, what we follow in our hospital, we give posterior subtenance. Because of seeing all this, we give posterior subtenance, triamcinolone 40 milligram per ml we give, and we investigate for tuberculosis, and then only we start on IVMP, because it could be fatal in case we start IVMP with any tuberculosis.
Thank you, ma'am.
I think Priyanka is there.
Any other questions from panelists?
So we go on to our, maybe she would be, another one is also there. So Dr. Priyanka, unusual coats-like response in occlusive retinal periphlebitis.
A very good morning to one and all. I am Dr. Priyanka. I will be presenting an unusual case on coats-like response in occlusive retinal periphlebitis. Our patient, who was 42-year-old gentleman who gave a history of diminution of vision in the left eye for past 1 month, which was gradual, painless, progressive, and it was associated with flashes and floaters. There was no significant negative finding and no systemic comorbidities. The systemic examination and gross ocular examination was within normal limits. His right eye was emmetropic and no significant anterior segment findings in the right eye. Whereas in the left eye, the vision was 6/24 and there was retrolental cells present, but there was no RAPD. Left eye fundus examination revealed media haziness of grade 1 with disc margin which is present more in the nasally. There is also presence of cuffing noted along the peripheral venules, suggestive of active periphlebitis. Temporally, there was collaterals, sclerosed vessel, which is suggestive of old vein occlusion. Somewhat inferiorly, perivascular exudation and retinal hemorrhages, along with the retinal thickenings, which is suggestive of recent onset of branched vein occlusion. There was also ill-defined subretinal exudation, and there was few odd exudates in the fovea. To summarize, a middle-aged male with a progressive diminution of vision in the left eye, associated with flashes and floaters, with a vision of 6/24. On examination, there was mild vitritis, cuffing of peripheral veins with multiple venous occlusion and perivascular exudation, suggestive of occlusive periphlebitis. And there was also subretinal exudation and diffuse telangiectatic changes with peripheral microaneurysms. These 2 points us towards Coats-like response. So my clinical diagnosis will be occlusive retinal periphlebitis, secondary to Coats-like response in the left eye. I would keep my differential diagnosis as Eales disease since the patient is young, and CMV retinitis, Behçet's disease, and IRWAN. We investigated with OCT macula in the left eye, which showed increased central foveal thickness with the presence of epiretinal membrane and cystoid spaces. There was also subretinal fluid with hyperreflective foci. There was also retinal thickening along the area of BRVO. Left eye fundus fluorescent angiography showed blocked fluorescence at the area of retinal thickening and hemorrhages. We could also appreciate delayed filling at the area of branched veins, which is suggestive of BRVO. And there was multiple telangiectatic vessels and few microaneurysms in the temporal and inferior retina. Progressively, there was leakage from the peripheral veins, which is suggestive of periphlebitis, which was increasing in size and intensity from the veins and the optic disc. Here we could clearly appreciate the progressive leak from the microaneurysms, and multiple telangiectasia was also seen. The systemic examination and blood investigation was within normal limits. So we started him on oral steroids, 50 mg OD. We tapered slowly over 2 months, along with topical NSAID eye drops. Clinically, we could appreciate that there was a symptomatic patient was improved and media was getting more and more clearer, and there was gradual reduction in the SRF and reduction in the retinal thickening over 2 months. So when there's a picture of retinal telangiectasia with aneurysmal outpouchings and odd exudates, we should always think about Coats-like response. In various literature, they have told that the Coats-like response can mimic different diagnoses, such as retinitis pigmentosa, retinal vasculitis, pars planitis, MACTEL, ischemic BRVO, ROP, and in our case, occlusive retinal vasculitis. Coats originally described the picture as congenital telangiectatic retinal vessels with subretinal exudates with or without exudative RD. But in Eales disease, which is our first differential diagnosis, is also an isolated vasculitis affecting the younger men. Here, occlusive vasculitis is a classical clinical feature. IRWAN is also a rare clinical entity which affects artery more than the veins, which affects young males with systemic comorbidities. Here, macroaneurysms can be considered as a disease-defining criteria for IRWAN. Here, learning points from this case would be that even in chronic BRVO, we can see microaneurysms, telangiectasia, and mild exudation. Coats-like response with severe subretinal and perivascular exudation is a rare presentation of occlusive retinal periphlebitis. A good clinical observation and fundus fluorescent angiography helped us in arriving at our diagnosis. So, a control of inflammation with only oral steroids showed a dramatic response in our patient by resolving macular edema and retinal thickening. Thank you.
So I think it's a very good presentation because we do see this occlusive vasculitis. And just one question. What were the investigations you do for this patient? Because you just mentioned some few TLC, DLC, but any specific? Because again, it would be like
it could be actually
diagnosis of exclusion.
It could be CMA retinitis also because the picture looks like frosted branch angiitis. We did serology to rule out HIV positive.
So did you do all those tests?
Yes, we did.
Achha, you did not mention that. You have to rule out because it's just a response which you're saying which is Coats-like, but it could be any of those occlusive vasculitis which you have to rule out. So there's a list of investigations, especially tuberculosis once again, and CMV. And thank you. Any questions for her?
The representation of fundus pictures is very good.
Thank you.
Very good.
Thank
You
you.
did a very good job.
So we can go on to the last speaker of this session, Dr. Shrini Jogalkar.
Not there, ma'am.
She's not there.
Not there.
Any speaker who has come a little late? Your good name, please. Please come. Dr. Sayali Shaha.
Acute retinal necrosis.
Dr. Sayali. So she'll be speaking on a
Acute
case of
retinal necrosis.
Good morning all. Today I'll be presenting a case of acute retinal necrosis, the diagnostic dilemma. We had a 69-year-old female who presented with right eye diminution of vision and complaint of floaters since 15 days. She had received oral steroids at another center for diagnosis of right eye choroiditis. She was hypertensive and on treatment. Ocular examination at our center showed right eye vision at finger counting 2 meters and anterior chamber showed cells 2+ and flares 2+. So her fundus findings showed arteriolar occlusion, there was vitritis, there was a patch of peripheral retinitis, and there was traction. So our working diagnosis was acute retinal necrosis. We started her on oral valcyclovir 1 gram TDS and ecosprin 75 mg OD. Topically in right eye, we started prednisolone acetate eye drops and atropine eye drops. We sent a lab workup of HIV, HBsAg, HCV, Treponema pallidum, and toxo IgM, which came in negative. However, toxo IgG was raised. So she started improving steadily, and we had her on low dose oral steroids for inflammation. But she presented with worsening at 4 weeks. So vitritis had worsened. There was peripheral retinitis patch which did not resolve at all over the 4 weeks with oral valcyclovir. So new lesion, there was a new lesion of focal retinitis. The traction had increased, and we decided to perform a diagnostic and therapeutic vitrectomy. So a 25 gauge pars plana vitrectomy was performed and intravitreal ganciclovir was given. Samples were sent for gram staining, KOH staining, bacterial and fungal cultures, and PCR. PCR came in positive for toxoplasma. We started her on oral sulfamethoxazole and trimethoprim, and with subsequent follow-up, she started improving gradually. So these are the images. We can see that there has been a good improvement. So coming to ocular toxoplasmosis, it often presents as macular involvement with focal necrotizing retinitis, associated vitritis, and at times with anterior uveitis. Clinical diagnosis without laboratory confirmation of T. gondii infection. The lesions are often obscured by severe vitritis, producing a classic headlight and fog sign. Unusual presentations of toxoplasma include punctate outer retinal toxoplasmosis, retinal vasculitis, retinal vascular occlusions, unilateral pigmentary retinopathy mimicking retinitis pigmentosa, rhegmatogenous and serous retinal detachments, neuroretinitis in forms of optic neuropathy, scleritis. In our case, retinal necrosis was peripheral. There was occlusive vasculitis, which is an atypical presentation with retinal arteriolar occlusion. This delayed both diagnosis and treatment, so it needed a diagnostic vitrectomy. It can mimic acute retinal necrosis of viral etiology. Prognosis is definitely poor if unidentified and if there is unrestricted use of oral steroids. These are my references. Thank you.
Thank you, Dr. Sayali. It's a very good presentation. Just like your IgG was positive in your investigations, so that could have given you a little hint, though, to do IgM also.
Yes.
So you did not do IgM toxo.
IgM came in negative, ma'am. IgG
Okay.
was positive.
Okay. And what type of a diagnostic PPV did you do? A complete, or you did a core vitrectomy?
Complete, ma'am. Complete vitrectomy.
Because in acute retinal, there are chances of the retina is very thin
Yes,
and
ma'am.
friable.
There was traction
So
as
there
well,
was.
ma'am.
Did you put silicone oil also after that?
Yes, ma'am. Silicone oil was put.
Okay. All right. Thank you.
Thank you.
You said that you started low-dose oral steroids. So how much did you start and how did you decide? Are there any guidelines and what was the rationale?
She was started on Visalone 40 mg with tapering, ma'am. And as soon as we got the results, we changed the treatment to oral sulfamethoxazole and trimethoprim. So we monitored the response and then we tapered the steroids. Thank you.
So that brings us to the end of this session of ocular immunology. Any questions for the speakers or for the panelists? If there are none, then we can take a little break or straight away go to the next session. Next session would be on vitreoretina. So there will be a slight change in the panel. We'll have a photograph. Please.